Okay, let me check this. Yep, it's recording. Oh,
We're
yep, there's a
okay.
red button now.
Okay, thank you so much.
No
All
problem. So
right.
I'm just going to minimize it. So go to her.
Thanks,
Okay. Thank
Sheila.
you. Okay. So I will just start in and communications can start editing here. All right. Welcome. We're going to do a critical care expanse demo video today. So what the plan is we are going to walk through a patient that's been admitted to the ICU and show you some of the features and functionality of expanse. So we've started with a patient that was in emerge and has admission orders to go to the ICU. So we'll show you that process if you want to take over there, Joe.
Perfect, I will do. So I'd already had this room, we'll say add it to my work list. So then this patient obviously then flopped in when registration said, yep, this patient's coming over. You would obviously emerged as a TOA, as do we. I didn't actually build that into this one. Whether your process is phone or go pick up the patient, that's obviously site specific. Even though this patient has been assigned to the room and they're coming over, you're going to see then all the last data that was done previously in emerge. Pardon me, I was going to go back to my status board there so I could see the transfers. And the work list on this patient will go through as we get further into it. I want to be on the right patient there. So here you can see those are the vital signs that were done previously in emerge this morning at 8:46. So whatever was last done will auto-populate over. Whatever they've done, the next MARs that are due, and this is what they call target order. So if there was specific ones for, say, blood pressure medications or where they want oxygen levels, they're called targets, and you'll see those on this detail box on the bottom. So if I went to open up the chart, I've gotten a report from emerge, and we're going to say they've kind of given a quick handoff because they're super busy and maybe they haven't processed everything like they should. So if I go to click into it, right away you'll see that a transfer exists on this patient. So as far as we've been told, and again, it'll be site specific, Collingwood doesn't have closed ICUs, the rest of you do. So this transfer order would be sort of from emerge. These are the transfer orders to get the patient to ICU. Once they get to ICU, then obviously your internal med for your site will do it. Ours probably won't do transfer orders from emerge from CGMH just because that's just not the way they necessarily do it, and we're really small. So normally you would want to see the transfer orders because what the transfer orders do, and you'll see when I open it up, are what the physician has decided doesn't need to carry over from emerge. They got a one-time dose of antibiotics. They don't want to continue over. They want the hospitalist, they want the internal med guys, team, respiratory, whoever wants to see them, to add their own orders. So that's how it's going to look. If you need to just open the chart, you can still do that, which you saw me do a few minutes ago. But for the sake of this demo, we'll go to transfer orders first. This automatically comes up as soon as you do that. So you'll know that the transfer orders were from that doc that had seen them in emerge. You could really pick any other one. It's not going to actually matter. It's just for you to access the orders, but pick best practices to pick the physician that had actually written the transfer order. So if it was Dr. DaCosta from emerge has written them, that's who I would pick. And you would see their name on here as one of the providers or the ED provider for that patient. So you'll see this little flag here, transfer orders. Quickly just looking through, these are all the orders that had been ordered originally by the emerge ED doc. And you'll see in here what's already been changed on her side. On transfer, she wants these things. She wants certain things stopped. There's a stop, continue, etc. So then at the bottom, they will be changing some of this functionality. There's been a bit of a discussion for stop all, hold all, continue all, because they don't necessarily want nursing to do it if a physician has already decided what they would like to see. So these three may disappear when we go live. That's a bit of a point, sort of professional practice legality wise. But what we would do is process the transfer. If there was something you didn't want to do, so say I only care right now about getting the antibiotics, you can pick them individually, but for best practice, we're trying to tell everybody to transfer all the orders because that way things don't get missed later. So process the transfer orders. Okay, yep. So now all those orders that were sort of pending and transfer for me to do will now be active. So if I went to, which we've shown you before, and I'm just going to refresh just so we can see. So then there will be orders that will have come through that we have processed that we want to do. So acknowledge your orders. So here's what they all were. Ordered, active, collecting. And what will come up here, sorry about that. So what will come up here is if for some reason any emerge nurse didn't get a chance to do the orders, it will still come over. We will still see it, even though it was maybe done, ordered in emerge. Because of that transfer order routine, nothing should be missed. And if they had started something and done one of the orders, it would be processed like normally. So I kind of equate this to thinking of your order sheets. If a nurse has written right beside, I gave this antibiotic, they would check it off here, file it, acknowledge it, and then it wouldn't be on us to do that. So, because I know what they all are, I'm just going to check them all. I'm going to acknowledge them all. I'm a really good nurse. I've read through these all. I've made sure that they're appropriate. And this is just acknowledging the orders. The doctor has done these orders. It's a transfer order. So I want to see them all and get them on my patient. Give it a second to save. And obviously, because we're doing this in a test, medications are not going to be verified with pharmacy because this is a test patient. So now there's no orders left to acknowledge because we've done them all. Opening up just a work list. So this is everything that's been done at an ED. ED does have standards of care for each patient. So you would see that on there, whether it's a respiratory or burn, skin, wound, you'd see those assessments that they've already done and anything that's left to do. So here they never did the blood culture draw. So it still shows it's pending and that we would have to collect and do that or notify the lab, however each facility works. CGMH, we have the lab come to our ICU, but our emerge nurses collect their own blood. So this is just to say either if you don't do it yourself, you'll have to phone and notify the lab and change it and let them know that they have to come up and collect it. But this is showing it's outstanding because nobody has collected it. That was what the order was. And this is where it says pre-collection label. So again, if you don't do it yourselves, they don't have a central line, you don't do it through an art line, etc. And this is not appropriate to you, you would have to go and change the order just to say that send lab to collect. And that's just letting the lab know that I did draw the blood because I'm a super good nurse and I got it from a peripheral line. So these are, as I said, what's left over from emerge. So now this patient here, we would add, before I add the standard of care, really quickly, I'll go back and just do a few points just in case you guys haven't seen it before. So obviously code status was not ordered. They are hoping that that will be, in future state, something that physicians do on a more regular basis than they do now before they even leave emerge, have that discussion. We know that doesn't always happen, but if a physician has changed on their side, you will say this change. There's going to be limited and no resuscitation, not unlike current state. Height and weight, they do that right from triage, so that should be there, especially the weight, age, if they have any allergies. Do I do standard of care, Tracy,
Perfect.
or the summary
So
next?
then, let's add this. Well, look, standard of care. Let's put on the standard of care so that we can see how that stuff all gets added.
So standards of care. It's not ICU. It will be.
Oh, the one below.
Wait. It will be critical care, not complex continuing care like I picked. So yeah, it won't be ICU specific. It's critical care. That was a movement they done for future state. This will come up. So again, these are because Emerge had added some intervention. So we were all resolved now just because we're anal ICU nurses. We like to make it really pretty. And this again kind of speaks to your current practice. You want to just keep the vital signs that were on there. You don't need to because you're going to see it in your vital signs over here, what's been done. So you don't need to keep theirs. You really would prefer to add the ones that are your actual standards of care, that your telemetry is done Q4, your in and outs are done Q shift, and that your vital signs are done Q1.
Right. It'll have the frequencies for critical care.
Where if they've been added as a miscellaneous, you see the MIS, that it's been added as a miscellaneous, you can do that at any point, add intervention if you want to, but they don't always have associated times with it. So we'll just inactivate those ones, keep the ones that we want. And again, if you added them all to your work list, it doesn't do any harm. It's just not as pretty for you to look at. And we like pretty. So then this is basically the standard of care that comes. Your admission assessment adult, your risk assessment, which includes your violence, your Braden, Canadian Nutritional Scale. I think that's it. Height and weight is on here as well. Even it does not have to be done if it's already been done. If you want to redo it, do it on the bed, do it on the scale as appropriate. You don't trust Emerge or the patient, you can redo it there. The vital signs to what the ICU standards are. Our physical assessment is Q4H. We'll notice on the floors, it's not their standard of care. It's just Q12 or Q shift beginning. So that's pretty much what ours looks like. The invasive ventilation is on there. That's a standard we can get. Obviously, if you don't need it, you could complete it out and get rid of it. Because not every patient's obviously going to have that. Your TOA.
So the TOA, something of note is that it is going to be done at, obviously, the beginning of your shift, and it's documented on by the nurse that's going off. So the nurse that's coming on doesn't need to document that they've received that. It's included in the just because that was quite a discussion with professional practice who documents on that, and final decision was that it would be the staff that is doing the reporting.
Which makes sense. I think that's a common practice for what we do now. I'm leaving, Tracy. I'm telling you what this patient had done throughout my shift, throughout the day, what needs to be done. Some sites, it's a much more simplified thing. Again, we should know by best practice what we should do, but here's a reminder of the SBARD format. And just I reviewed everything. You will see clocks, a lot of clocks on here. This TOA is, yes, done at the beginning of your shift or your end of your shift. But it actually says 9 and 9 on the clocks. That's when they kind of decide it would be the best.
Okay. And then when giving the TOA, you're going to want to refer, you want to go back to like the clinical panels.
Oh.
And snapshots are kind of a good place to go for a summary of what's been happening with your patient.
Snapshots.
Shot.
We have a patient I've done some more stuff on.
Oh, sorry, I'm just going to interrupt real quick. If you don't have that critical care tab, down below is widget options. And you may need to have to add your critical care tab there. But it's already added on this patient.
And we have another patient I'll show you that has a lot more data on there, but this is a quick look like Tracy said, so you can open it up and are they on precautions, what their physical assessment like, what their lines are like, etc., so on and so forth. And then the clinical panels could be viewed over here as well.
And of note, the snapshot there is just the most recent. You can't do any trending. It's just the most recent information for each of those things. Whereas the clinical panel that Joe's about to show you is somewhere where you can trend information. You can't document on this. This is just to view. And we've kind of bundled in what we think you might need for a TOA, or if you just want a quick summary of what's going on with your patient, you can go to these clinical panels.
Yeah, that's a really good, yeah. So this is for trending. You can use it for reporting. Snapshots that is like a snapshot of what happened at that time. So you can't chart on that one either. It is just a quick overall look.
Right.
What else do we want to show them on here then?
I think that's probably good for here. We've kind of reviewed snapshot clinical panels. So maybe we have a patient who has more data on them so that we can show you the infusions. I know everybody's excited to see those and how they work. The critical care flow sheet and kind of what that's all about. So RVH ICU patient demo 2. There's information that we've documented on.
So do we want to just primarily look at the infusion titration to start off with?
Yeah, and I think infusion titration and as it relates to vital signs, because those two things are going to be going hand in hand. So if you're infusing something based on blood pressure, so how you can kind of open that up so you can see them together.
So there's your, obviously the most recent vital signs. This is a default for 15 minutes. You can make it 5 minutes. You can make it 6 hours, which we would never do. And only the data that's been entered obviously will show here. So if you do it from the work list, it will pull into here, vice versa. If you do it here, you'll see it in your EMR as well. You can minimize whatever you don't want. So if all you cared about on this patient was their blood pressure, then you could leave that sort of open, which a lot of us do, right? If you're doing your titrations to blood pressure, to means, it's kind of nice to have it right above so you would see. Little plus sign there means there's been something that's been documented in between. So if you see that here, so between 10:40 and 10:45, even though I have it set to 5-minute increments, I've at some point documented. It might not be one of these columns. It could be any of these vital signs anywhere down below. You would do that, and then you could open up everything and see where it was for that one. Toggle back and forth, obviously. So infusion titrations, this is everything that's infusing or titrating. So whether it's a PCA, I did put this one in here just to play with to see. So if you want to do your checks and you're in there and you need to increase or decrease your dose, you could do it there. If you happen to be doing your checks, you could do it there as well. Any of the medications that are here, they also obviously live on the MAR. It's the same functionality. So a lot of drugs we know need a double check. So even if I go into any of these medications, even though it's on a basically IV flow sheet, for lack of a better word, and I titrate infusion up and down that would need a witness, either as a cosign or as a PIN, before I file it, it will come up and say I need that done. Same as on the MAR. So you can see this patient's on a lot, but not uncommon to what we may have. So dopamine, fentanyl, norepi, propofol, rock, vasopressin, KCl and sodiums. These were boluses that the doctor ordered me. And you can see when they're next actually administered, the times where they should next come up. This one I've missed because I was a bad nurse and got busy doing other things. You would also see that if you went to next meds up here, it would tell you what is due, when is due next. That's your next task. So next task would be your next set of vital signs that's due, your art line assessment, intervention are the same, your art line assessments, et cetera, what you're late on, purposeful rounding I was late on. And you could actually click them all and then go to your work list from here and do whatever's not on here. So this will tell you when it's ending,
also, just
what the
before
rate
you
is.
go
yeah.
forward there, I was just going to say that middle bar up there, no order activity, that's where you're going to watch if the doctor enters any orders, it's going to pop up there.
I would say new orders and a little green flag.
Yeah.
And this will have your current rate in here. not what is ordered. So if the doctor has ordered a rate of 4 to 5 mics or 0 to 300 mics or cc's or mils, whatever they're ordering, this is only going to reflect what I actually put in as my infusion rate. So that's something to be aware of. If you actually want to check it, we'll just pick dopamine to start with so we can open it all up. So then that, all those little letters basically bring you back to sort of the MAR and the details that would be there. So the A is for your associated data. Again, here's where we talked about for those target measurements. Your M will be your monograph, which we're all familiar with. Every drug is going to get them, which is kind of nice. Monographs can be printed out. P is whatever protocol or taper that they're on. So this one's a quick look. The dopamine, the doctor. Most of these as well will show you what the doctor's orders look like side and what kind of pre-selected for them that kind of flows back to us. But there's your minimum and your maximum. So in theory, if this is one of the drugs that you need a cosign or a pin on, you really should be that reflecting with them and telling them I'm going up to 20 mics, and that's what the doctor has ordered. Label comments, that's from the pharmacy. We have nothing to do with that. That just, oh, sorry, that's the fentanyl, but it has to be refrigerated. And the titration, which is what this is. So again, if you went to the MAR and you actually clicked on that, because this is the titration sheet, it would take you to the flow sheet, but we're already on it. And this is your little, what we call gas gauges, and shows you how much is left. So again, it's kind of a quick reference. Like when you're looking really quickly, my fentanyl's fine, my dopamine's fine. Ugh, I'm probably gonna need more vasopressin, so I should call the pharmacy to bring it up or get my friend to make it, or however you do it, wherever you're from. And if you went to that first one, that's the actual whole prescription of whatever the doctor ordered as well. If you wanted to and actually go back to the entire order, you'd actually do order as well. So that has whatever the parameters was, but it actually also has who did it, when it was done, that pharmacies received it, what the last dose was that was given, et cetera, so on and so forth. We are working on hopefully trying to be able to do a printed report for this, which we don't want to print out things. We're aware of that. But if I'm in an isolation room with a patient, COVID, for example, and I'm titrating drips up and down, it would be nice that the person I'm doing with on the other side, because we're supposed to be doing it kind of together, like would have a print of it, or I'd have a print of it in the room and I would know. I could show them through the window of what the actual order was so they know that what I'm doing is correct, or vice versa. So IV site, again, because it's 15 minutes increment, you do not have to do the IV site every time you go in. If you want to, you can. If you want to scroll back and see what it was, what site it was, you can go back through and see it. Most of us won't do that. Because if you've done the first year shift, this is my whatever left upper site I chose, we're going to just keep it. So every time you go in, if you're titrating drips, you do not have to go in and do that. There is no, this is obviously the only part that actually says required. That is the mandatory field for you changing it. Sorry, I learned to go back to current time. So intake, because we're going to be scanning the med bags, we won't need to do this. But if your bag finished earlier than expected, then you would put the volume in that was actually the total intake of the bag, and that signals the system that we're done with it. So it would end that bag for us. Then it does the other calculations of the cumulative intake, outtake, if there's any waste volume in there, and it obviously goes to our in and outs on our EMAR. So this patient, I don't know what I have it running at, but let's just go. I'm going to go up to 6. And it'll actually tell you then, it auto calculates, which is nice because the docs order it in mics per kilo. So I want it to go up to 6. Then it's going to do the cumulative dose rate as your 28, and it shows it's increased. So again, later when you're editing it, looking at it through the EMR through here, you can see how much it went up and down over the course of your shift. And then it's telling me there's 2 hours and 30 minutes left of that one.
And you can kind of scroll up and just have a peek at your blood pressure, see what it was at the time, or document what it is at the time.
Yeah. So, oh, sorry, that's my bad. On the other side, you can do comment field. So if you want in that comment field, you can actually put increased as per parameters. You do not have to do that. We know that. Some of us are anal like to.
It's just a little comment for whatever you want to put in there.
Yeah, so then someone could come by later and be like, well, I wonder why at that time they did that or what their blood pressure was. You know, nitro tried to increase, patient too sensitive, pressure dropped, or whatever you're doing. So there, 80 on 60, so I went right down to my dopamine, I increased it. And that's how you would do that.
You can change the time.
Yeah.
It's just a right click, isn't it?
Yeah. Column time. So that was actually at 11:43 I did that. And obviously, same parameters and same rules exist. You can't undo somebody else's. You can only do your own, and you only have like your 24-hour sort of data window to do. If you want to see what all this stuff was, you're like, oh, what's this supposed to be? And it's been cut off. You can expand it, make it bigger, in case there's anything that you didn't really know what it was that was there. Anything else on here, Tracy, that I haven't shown?
Just kind of show, like if you open up, you're doing your, now you want to change your fentanyl.
Mhm.
It just kind of keeps opening up.
Yeah. Again, it'll keep calculating for you. Norepi.
You can do it in real time, change the time.
Yeah. Yeah, I'm kind of backdating it here. And do that.
You can also show. So
Yeah.
if you go back up to the first one.
Yeah.
Okay, so the dopamine.
Mhm.
Go to where we documented that. And if, so save it.
Oh, and this is what I was saying, the same as you can't, these are the parameters you're set in. So I'm still adjusting the drug, even though it's on the bag, not in the MAR. You're going to still need your friend. And those ones are obviously both ones that need a pin and a cosign. Some are just cosign, some are pin and cosign. And that was a pharmacy best practice decision that we didn't have a lot to do with.
Are you aware, every time there's a titration, do you have to get a sign?
For certain drugs.
Certain, okay.
So
I know we tried to make that a very small amount of.
And we did reduce it a lot. A lot of the inotrope, we got down to just a signature. So basically I could say, Tracy, I'm just changing this. And you'll say, fine, go ahead. And I'll put your name in. There are certain ones, so the fentanyl one specifically that had popped up because they'd done them at the same time. The fentanyl one needs a signature. This one happened to be put in as because it was under PCA, the drug string. So those are the ones that if you're adjusting that one, PCA epidurals,
Okay.
there's way less in the original list that was put out. And some are just a signature, like I'm putting Tracy's name in for her. She could come over and do it herself. But the pin is Tracy has to be there and actually watch me make sure that I didn't kill the patient by changing the infusion. Sorry, Trace, what do you want me to show on here?
Okay, so go back to the documentation.
For the dopamine, you mean?
Dopamine,
Here?
sorry, yeah. Okay, so now dopamine, all of a sudden, it's a peripheral site and it looks like it's gone interstitial, so we want to pause it. So what you do is go down to the dose. Oh, I'm trying to remember. Go down to the.
Do not change the dose rate to 0.
Go to 0.
And then it pauses it for you.
Right. And if you save that, it'll remain paused.
Yeah.
Until you restart it.
So by the way, dopamine obviously requires a pin and a signature.
Okay, it's paused.
Yeah.
So then, if you go in and restart it, there's a method to my madness here.
Yes.
So we've checked it. It wasn't actually interstitial. It was false alarm. So we're going to restart it.
So there.
And you can see
that
it's been resumed.
Yeah.
And everything is as it was because you're resuming it at the same dose. So
I
save
did
that.
pretend, yeah.
Okay.
Oh, sorry, that's her code if anybody wants to use it. She will be changing that when we go live. Okay.
Okay. But then, okay, dopamine has been discontinued. So rather than just putting in that your dose rate is 0, what you have to do now is put in your waste amount, which will give you, okay, so if you put in 0 for your dose rate.
Oh, I want 0 for my dose rate. And my waste amount, let's say I wasted 25 mils. Will that work, or do I have to put my total in?
You didn't do your dose rate there.
Oh, no, I didn't. No,
That was your...
Wait, that was me. Wait 1 moment. Just ignore this.
Okay, and your waste amount put in as your 20. Okay, so then your dose rate remains at 5 then. I'm sorry, that was my mistake. You just don't do anything with that. Waste amount is 25. And the bag amount.
I don't think let me do that.
Do we know how big the bag was? It's right here, 250.
250.
But if we put the waste amount, it should...
There. So if you want to stop like we're complete, that's what you do, is put your intake volume in.
Okay. Sorry about that. You want to stop the bag. You put in the intake volume. How much has gone in at this point?
Yeah.
We're done. And then you can also add your waste there. But in order to have it, the difference between paused and it's infused, it's done, you want to manually add your intake amount.
Yeah. Is what you have to do to make it think that it's went through. So you could put the intake there, and then you can put a waste amount in if you want it in here, that there was actually like 50 wasted or whatever, and also the auto calculations for you, and actually stop the infusion.
Right.
Is what it should do.
Okay.
Which is nice for the pause part. If you guys use heparin drips a lot, that you're constantly like changing it based on their PTT and whatnot, that's a nice way to do it, that you stopped it for half an hour, pause. You can see that I paused it for half an hour. I'm restarting at whatever rate the physician's ordered, or whatever kind of infusions you may run like that. It's kind of nice to have.
Right.
So,
okay. And then this flow sheet also is completely customizable to what you want. It'll come with a default. So all these, the waveform capture, cardiac monitoring, but you can go in and change by going over to your items at the top there. And you can also change the order of them. So if you prefer a different order, you can save it to your preferences.
yeah. So if you want to get more, these are everything that's been associated with a special care flow sheet. Be aware that special care flow sheets also involve things like NICU. So you're never going to want to go add in there things that are newborn, because they just don't make sense. And also the one functionality of this, which is good or bad, however you want it, is that if it's not on the master, we'll call it the master one, has basically everything down to the MAR. This is your standard that will come up no matter what, all the time on your flow sheet. As soon as you document something on your work list that's on the specialty care flow sheet, it will automatically go over and be on here for you to access. And like Tracy said, if you don't want it, I don't want to see that neurovitals, it was just a one-time thing and was done, then this is where you would go in And I don't want to see neural vitals. So that's taken out. And I don't really care about the chest tube because they've had it forever. I don't know. So then when you do that, then they won't be on your flow anymore. You could suppress everything if you want. So you wouldn't see anything on the flow sheet, but you won't want to do that. And there are templates available, but the only one available to use your critical care flow sheet. The other one's the NICU one. And you can see those two that I just took off aren't there anymore. And if you want, so this is what you want to see your sheet all the time. Oh my God, I love this. This is so amazing. Then you can save this. This will save in this format for this patient for you. If you had a patient that was renal and a GI bleed and you were super concerned about their, I don't know, gastric losses and just their in and outs, I don't care about anything else, you could just add those two to that patient and you save it. And then every time you come back to that patient that you have saved that format on, that'll be there for you.
Yeah.
So you save the current state of whatever you want. And again, or restore it to whatever it was before, which would just give you these 5 back. It's pretty user-friendly. So play with it. If you do get in there under items, again, there might be something that we didn't add that you think is amazing, and you should always see it on your patient every time.
And then those little squares at the bottom, medications, that gives you your active meds.
Last dose administered. It's a really quick overview. Obviously, if there's something infusing, it just says sort of what time it started at. It won't give you last dose per se. Calculator's there if you want it. We're supposed to use our phones now, but and that's how to save your preferences, change them, etc., so on and so forth for whatever you want up here from your flow sheets. And there's cumulative in and outs if you wanted to look at it there as well. So you can change it if you only want it in 15-minute increments. Same thing. Get rid of the ones you don't want. And then you can save the setting for that patient. And again, it only saves for you for that patient. It's not, you're not changing what I see when I log in separately to this patient. I can set it up however I want for the patient, which is kind of nice. Because again, we all have a bit different practice for every one of us. So it's kind of nice that way. And then to refresh it, obviously just refresh that. And then that would just show you if there's more in and outs occurring. So
Okay.
There's your hemodynamics. This will be for whenever you guys get your monitor capture and things like that will eventually come across here. That's, I know for most sites, being a work in process right now. But this is where the data will pull in. And then hopefully eventually when we get the waveform actually capture, that we can do the calibrations with our calipers right on our screens for future state optimization. Bedside bulletin, we didn't really touch on that. That's one, it could be used in ICU. So I said this patient asked for his last rites on the 13th of August. So I phoned the family, let them know. This is not a permanent part of the patient's record. This is just more truly like a communication tool to the other team members. The physician said, I'm coming in tomorrow morning to do an extubation. You could put that in here in case it's been a busy shift and you forget. Anyone can look at this and access it. Any member of the team can add notes to it. So your RTs could, physio could, et cetera, so on and so forth, who have access to this chart. If you want to remove the note, though, only the person that put it in could do it. So Tracy can't remove my note. I can't remove hers. You can do it for date of future as well. So you can do it that way. Sorry, it's not opening.
Composed by date.
Composed by date. Oh, just let me do that now. I don't know why my little finger's frozen, so it's not working. Anyway, so that is there. So you could see it. I think I said this patient's family's coming in from Dubai. So you should be able to see that and look at it as well. So, I lied because we were looking at today only, pardon me. So you can open it up and there you go. So the brother's going to arrive to Dubai. He has permission to see the hospital. Even though even though it is not part of the permanent patient's chart, it is discoverable if they ever do audits on it. So obviously we've been told to tell everyone to make sure that your notes are professional. So that's kind of it for that one.
Okay.
What else
Did
on
we
here,
want
Tracy?
to go over to clinical panels? Because this is the patient
Sure.
that has more of the
Yes.
data on it, just to have a better look.
Which do you want to do? I'd plop in the
Critical care general.
okay. So unfortunately, we don't have any labs to show you. So
because this patient has had a bunch of assessments done, you're going to be able to see them on the clinical panel. And again, you can collapse or open these to kind of see what do I really want to look at.
you don't
And
care
this
about
is
vital signs. You only want it neuro. There you go.
And this is the view only. So kind of on that right-hand side, you've got your view section at the top down to orders. So all of that stuff is just view.
View, do.
Yes. Orders down is stuff that you can document on. So again, this is good for giving report, getting an overview, maybe during bedside rounds, interdisciplinary rounds. It gives you that trending information for each of the systems. Lines. There is a list of
nice.
medications. But yeah, you've also got your active medications that you can pull up there.
Yeah, this is a nice review, in my opinion, for the medications administered. You can kind of see what the rates are running at, when they were changed, et cetera. This one just kind of gives you an overall list of active medications that are on their Mars, but doesn't let you look into it. And you have your cumulative in and out there as well, which is nice too.
Oh, yes. Yep, it's a good breakdown.
Yeah. So, they've had hardly any propofol. That's probably why they're so agitated or restless. Or they've had a lot of dopamine. So doctors, I mean, we might like it too. You can graph their vital signs too. Obviously, this gentleman was just admitted today. So there aren't a lot, but you could see it over time of where their blood pressure, their heart rate, respiratory rate, SATs are going, which is nice for some of the other allied members of the team too, right? What else do you want to see in here, Trace?
And maybe one of the last things is that transfer report.
Yeah.
If you're transferring a patient out of your facility.
You can't do it from our specialty care management desktop, right?
Right.
So then you'd have to go back into
unfortunate, but that is
a functionality thing. Oh, pardon me. Sorry, I was doing some testing earlier. Let me just get a better. Let me get out of my and change my. There's my list.
So at the beginning, if you want to just go back and just show them how to
Sure.
get to
PCS status board.
Yeah.
You guys should have both options. So specialty care desktop, that's for the critical care areas, ICU, NICU, CCU eventually, et cetera.
That's where you'll do your documentation.
Yep, OB has specialty care as well, Tracy. OB does, I believe. Yep. PCS status board is sort of like what most of us have, quote unquote, current state now. It looks very similar from this. It's just the other one you can flow a bit more easily with the specialty care flow sheets from there. So pick my patient.
Actually go to patient. Oh, no. Go back.
Back, one more.
So just patient reports on the right-hand side.
Oh, sorry, my bad. One moment. I want patient reports. Pick my patient. There we go.
And then you click in the little box who you want the report on. Click your report. Up here, there's all kinds. There's the one you're going to use the most is the external transfer from ICU. There is also a code blue report in here, which is a quick summary. You can click on that, and we can also click on the ICU one. So you can click both of them. So yep, okay, and then we'll preview. So this one is the code blue report. It gives you just a.
Sorry, I got clicking too fast there. Perfect.
Okay, so yes, this is the code blue one. gives you their demographics, the substitute decision maker, height, weight. It'll have should have the BMI calculated, vital signs, temperature. Oh, sorry, vital signs. Yes.
Sorry, keep going.
Yep.
Sorry. I put a lot in for this patient, obviously. So
Active medications. And it should have at the bottom, it's not entered, but their family, their medical surgical history. So it's a quick, you can print it out, give it to the responding code team as a quick summary. And then if you go to the transfer, the external transfer report, if they're being transferred out of ICU, it's going to have a lot of information. Again, the demographics, a spot to put the MT number.
that's obviously, we have to write that in. There is no way to build in the system to pull it over because it's external. So
again, vital signs. And if something's documented on, it'll show up here. If it's not documented on, it doesn't even show up. So it's got oxygenation, ventilation, your ventilator information, IVs, if you have any tubes, nasogastric tube in this case, details, again, active medications. So pretty much everything you need to be able to give that information to the facility you're transferring to. It will also have the medical history, family history. And then, so that's it. You just click the one button and
the only thing you have to remember is go to your PCS to do it. The reports that are in the patient's chart, once you get in there, those are like physician reports, CT reports, et cetera, so on and so forth. So it's the patient report you want, which makes sense.
We need to show the summary.
Yes.
Quick.
So we can do it from here.
Yeah, when you admit a patient, you're doing your admission, physical assessment, your vital signs, everything. To do your history, your family history, your medical history, your psychosocial history, you go to the summary. And that's where you are going to enter your health history.
Which is kind of a change in practice for a lot of us because a lot of it has been sort of embedded into your normal admission. However, you're doing it on Meditech, you'll have to remember to go here and do it. One really nice feature is if I have done it and sent a patient to you from CGMH or to RVH, you can go in and you can just view it. This summary will stay with the patient. So the medical history I put in, you will see. You're still expected to go in and review it and make sure it's appropriate like anything else, but this is the one thing that will stay with the patient regionally as they go from site to site, and you should be able to just review it and know it's okay, which will be nice because the home medications here, your BPMH that your pharmacy will have done, they can review from here as well. Yeah, so it can be kind of nice. There are notes down here that we don't use, the bulletin board notes. I wouldn't advise to use them. They're nicer to have within the patient's chart. Your legal, this is your code status.
I was just going to say too, how to fill all that out and do it is all in the e-learning as well.
Yeah, it's pretty simple.
Yeah.
Edit and put it in there. This is one thing new that's probably not in the e-learning. This has come from the Ministry of Health that they wanted to kind of capture COVID vaccination status. There, you'll see on the bottom, which will not be there when we go live, it said something about immunization. They've decided as an organization not to use that. That was set primarily in the States for sort of primary care clinics. So there's nowhere to really capture that. So this here is how you would do it. And again, it's great. I started to give them their vaccine shots while they were at CGMH. Now they're going to rehab at GBGH. They can actually look and review that, oh, they at least got one shot. Obviously, it'll be in the MARS that we send with them, et cetera. Doesn't link to the COVAX site, but at least it's sort of on the patient's medical record or as to why. So this one here, if it's not completed and you click on it, you can actually put why. And all these codes within this sort of history part are all ICD code specific. So Heather was one of our team members that built it all. But then you can make a comment here too. Started it and developed COVID arm, couldn't continue. And again, that would follow the patient around, which is kind of nice. Social history is a bit different for most of us too. This will follow the patients as well. And we are trying to set it up that Allied has access to this. So again, not as much for ICU we would see, but if they're on the floor and they're having a social worker come and see them, or behavior change agent, they can actually fill this out as well. It doesn't just have to be nursing that could fill out the social history. So they're trying to make sure that's accessible. So this is a bit different too, based on what we've been asking before. A lot of them are sort of health indicators and have kind of come provincially through the team. Drug use is in the social history now. Your alcohol, drug use, social determinants are all within there too. Your cage, heart. So that's what's in the social history, and that's a bit different. But yeah, that's one little reminder that we'll have to do is this has to be done. Just remind yourselves.
Yeah, and there is a checklist that professional practice had requested on the work list. I think it's called the admission.
I think it's a mission checklist, to be honest, Tracy.
Checklist. Is it something simple?
Yeah.
Just to remind you, have you done A, B, C, and D? And it'll be included in there.
And your special indicators, right? If there are falls risk, et cetera, so on and so forth, violence score, Indigenous, that's where it goes as well. And again, those would stay on as per whatever your facilities is. The only special indicators that nursing are not putting on or touching that we've been told about is any of the IPAC ones. So IPAC at each facility will still be responsible for adding their C. diff, their MRSA, their whatever specific one they might need or want on there. But other indicators like falls and risk we can put on.
Okay, I think that's probably good.
I agree. 102, we did pretty good.
More than enough.
Yeah.
Great. So ends our ICU
Demo.
CC critical care expanse demo video.
Thank you so much.
Okay, bye.
Okay, bye-bye.